Hi there, I'm Dr. Brigid Norton. You can call me Brigid. This is Menopause Bytes, where I unravel the mysteries of menopause for you in bite-sized episodes. Today, let's dive into the buzz around testosterone. If you listen to social media, you might be under the impression that testosterone is a cure-all for everything. Low libido, fatigue, lack of energy, muscle loss, mood swings, and even brain health are all touted to be improved on testosterone. It sounds almost magical, right? But is it really? Well, the short answer is, unfortunately, and probably not surprisingly, no. Now, testosterone is a hormone, but it's not typically considered part of menopausal hormone therapy. Why is that? Well, in women, testosterone comes from three main sources: around 50% from the ovaries, 50% from the adrenal glands, and a small amount from what we call peripheral tissue like fat and muscle. Unlike estrogen and progesterone, testosterone levels don't drop sharply in menopause, nor do they fluctuate in perimenopause. In fact, your testosterone levels have been in slow decline since your early 20s, and studies show that there's no major change in testosterone levels during menopause or perimenopause. So that's why it's not considered part of menopausal hormone therapy. And I think it's also important to understand that there's no consistent link between testosterone levels and any specific symptoms. For instance, women with polycystic ovarian syndrome often have a higher than normal testosterone level, yet they don't typically come in complaining about their excessively high libido or unusually high energy levels. On the flip side, two women can have the same testosterone levels, with one complaining about a terrible libido and the other one not having issues with her libido at all. In other words, there's no clear correlation between testosterone levels and these kinds of symptoms. Does that mean that testosterone should never be prescribed? Well, not exactly. However, testosterone is not FDA approved for women in the United States, meaning there's no testosterone product specifically manufactured for women here, though one does exist in Australia. When prescribed in the United States, it is considered off-label use, meaning we use testosterone for an unapproved indication, and we use a product approved for men and adjust the dose for women accordingly. There is only one reason to prescribe testosterone in women according to the Menopause Society, the American College of Obstetrics and Gynecology, and other endocrine societies. And that is for post-menopausal women diagnosed with hypoactive sexual desire disorder, which is a clinical condition of low libido, which is different from the more common type of low libido that we all complain about. I'll be covering more about low libido in a separate episode. Now, I know a lot of you are hearing from your friends saying that they've noticed an improved libido, more muscle mass and better strength, more energy, improved mood and less brain fog from testosterone. But I really want to emphasize what the current science is telling us. At this point, there is no strong evidence to support testosterone improving mood, energy levels, brain fog, or hot flashes and night sweats at any age, nor does it improve low libido in perimenopausal women. Now, there is some data suggesting that higher than normal testosterone levels can increase muscle mass and strength. However, that benefit has to be weighed against the increased risk of developing visceral fat, which is fat around your organs, that can occur with high testosterone levels. And visceral fat is dangerous. It's the type of fat linked to serious health conditions like heart disease. This is a really important point to understand. Not only is there no solid evidence to support testosterone for things like libido, mood, and energy, but using it can come with significant risks. So before starting it, you really need to weigh those risks and benefits. Some of the other potential side effects from using testosterone includes less serious issues like acne or unwanted hair growth and mood changes like irritability and anger. But there are some more serious, irreversible effects like an enlarged clitoris, deepening of the voice, male pattern baldness, or an enlarged Adam's apple, and also the possibility of harmful effects on liver function and cholesterol, which could increase your risk of heart disease and stroke. Even with all these considerations, I still have women who want to try testosterone to see if it improves their libido and maybe other issues as well. If we are considering a trial, we usually start by checking some basic blood work like liver function and cholesterol levels. And then once you're taking testosterone, we have to monitor testosterone levels closely at 1 and 3 months, and then every 6 months while you're taking testosterone to make sure the levels stay within a safe range. Are there other reasons to run testosterone levels? Well, yeah, there are. I would offer testosterone level if a woman comes in complaining of issues that suggest to me that her testosterone level might be too high, such as male pattern hair loss, an enlarged clitoris, or voice deepening. I would run a level if I'm suspecting polycystic ovarian syndrome, and I would also run testosterone levels if a woman is using a compounded hormone product, especially hormone pellets, as the compounded market is unregulated, which brings significant safety concerns, including the potential for dangerously high testosterone levels. When I prescribe testosterone, I typically recommend a 3 to 6 month trial to assess benefits. I have women journal about their libido and any other issue they are hoping will be improved on testosterone, and if there's no improvement after 3 to 6 months, we usually stop the treatment, given the risk of potential side effects. So that's it for another episode of Menopause Bytes. Here are some take-home bites to remember. Testosterone is not considered part of menopausal hormone therapy because testosterone levels do not fluctuate in perimenopause, nor do they drop abruptly with menopause. Testosterone is not FDA approved for use in women in the United States, so it is used off-label for only one indication, in postmenopausal women with a clinical diagnosis of hypoactive sexual desire disorder. There is no scientific data proving a link between testosterone levels and specific symptoms, and there are some risks from using testosterone, including low-risk issues like acne and anger, to the more serious issues including an increase in visceral fat, an impact on liver functioning, and cholesterol levels. Until next time, may your hot flashes be bearable, your nights restful, and your libido not ghost you when you need it.